Buongiorno a tutti, benvenuti in questo nuovo seminario. Io sono Mauro Manconi, neurologo. Ci siamo già conosciuti su questa piattaforma per un precedente mio seminario e ho il piacere di essere ancora vostro ospite dell'Associazione Italiana della Sindrome delle Gambe Senza Riposo, che ringrazio per avermi invitato. Oggi sono con voi in qualità però di moderatore e introduco un esperto di medicina del sonno che abbiamo l'onore di avere come ospite oltreoceano, che è il professor Elias Karroum dall'Università della Virginia Charlottesville, un esperto di medicina del sonno che oggi ci parlerà dell'associazione tra sindrome delle gambe senza riposo e dolore. Prima di cominciare, due parole sul personaggio che abbiamo l'onore di sentire oggi, cioè il professor Karroum, il quale si laurea in medicina a Beirut, nel Libano, per poi prendere un dottorato in neuroscienze a Parigi e poi spostarsi nell'Illinois, negli Stati Uniti, dove diventa neurologo. Diventa poi specialista di medicina del sonno presso l'Emory University ad Atlanta e, come dicevo prima, oggi lavora all'Università della Virginia in qualità di professore associato di neurologia. È uno dei maggiori esperti di disturbi del movimento del sonno, è un collega che conosciamo bene e che si occupa per l'appunto anche da anni di sindrome delle gambe senza riposo. Il tema che affronterà oggi insieme a noi è molto interessante ed è quello del dolore nella sindrome delle gambe senza riposo. L'associazione tra restless e dolore è piuttosto intrigante, soprattutto per tre ragioni. Prima di tutto perché parte dei pazienti con la restless descrive la propria sintomatologia in realtà non tanto semplicemente come smania o fastidio, ma in alcuni casi, circa nel 20-30% dei casi, come dolore vero e proprio, quindi dolore come sintomo di sindrome delle gambe senza riposo, sebbene inusuale, presente. Il secondo aspetto è il fatto che quando in un paziente con restless c'è del dolore, dobbiamo stare attenti ad escludere altre patologie che possono causare dolore, che possono confonderci con la sindrome delle gambe senza riposo. In particolare nella restless pediatrica o del giovane, i cosiddetti dolori della crescita, mentre nell'adulto la possibilità di avere una sovrapposizione o una diagnosi errata nei confronti della neuropatia periferica, soprattutto del diabete, oppure della sciatica, cioè delle infiammazioni delle radici spinali lombari, che possono simulare, ma talvolta anche essere presenti insieme ad una sindrome delle gambe senza riposo. Il terzo aspetto è un aspetto del meccanismo, e vale a dire che fra i farmaci più efficaci nella sindrome delle gambe senza riposo, come forse sapete, ci sono gli oppiaci, cioè quei farmaci simili alla morfina. Farmaci oppiaci che sono fra i principali farmaci che si utilizzano contro il dolore, efficaci nel dolore. E quindi questo richiama la possibilità che il meccanismo del dolore in qualche modo possa essere legato con la sindrome. Questi sono solo tre dei principali aspetti che probabilmente il professor Karroum tratterà nel suo seminario. Quindi io introduco questo seminario ringraziando il professor Karroum per essere con noi e augurandovi un buon ascolto. Arrivederci.
Thank you for having me today to give that webinar on restless legs and the painful and painless forms. I'm going to start by, I have no conflict of interest as related to that specific presentation. My outline today for this presentation is going to be first talking about similarities between pain and restless legs, then discussing what we know about the painful form compared to the painless or non-painful form of restless legs, and then concluding with where do we go from here to further investigate that phenotype of restless legs. So first thing first, a summary of the RLS components. The core component of restless legs is a sensory component, right? So it's what we call like an urge to move sensory component of a focal akathisia. The scientific name would be focal akathisia, affecting the limbs mainly. Most of the time, it is associated with uncomfortable, unpleasant sensations that can amount to painful sensation, but not always. This sensory component or discomfort occurs while the patients are at rest, mainly in the evening at night, and they are associated with a motor component as well. Of course, the motor component, one is avoluntary, meaning because of this urge to move, the focal akathisia, the uncomfortable, unpleasant, painful sensation, the patients have to walk, stretch, massage their legs. It's an avoluntary movement, meaning they don't want to do it, but they have to do it. It's like a built-in tension that make them move to relieve that tension. And also there's an involuntary component called periodic leg movements that is observed, reported in the majority of patients objectively by doing a sleep study, polysomnography we call it. So what are the actual similarities that we know of between pain and restless legs? Starting historically, since the beginning, the first known description that we know of restless legs is done by Thomas Willis, the famous English neuroanatomist. And he did describe the first case of restless legs that we know of. And his description in a chapter related to insomnia specifically, he did describe restless leg, but also he describes a lady that belongs to the English aristocracy that he treated well with opioids. So as to say that from the beginning, it was related that restless legs may be treated with opioids, and therefore a hint to the possibility of the relation between restless legs and pain. Moving forward to the 18th century, the French physician, well-known physician, Boissier de Sauvage, who made a big classification of diseases based on species and genus, like we specify and classify plants and animals. In his Nosologia Methodica, he did classify restless legs in the seventh class of pain, doloris, first order of dolores vagi, so vague pains, fifth genus of anxietas or restlessness, and the fifth species of anxietas tibiarum or restlessness in the legs. Moving to recent data, have shown that most patients with restless legs can choose verbal qualifiers from the McGill Pain Questionnaire, or here in that case, the modified McGill Pain Questionnaire for French population. The majority of them choose words that are qualifiers of pain to qualify their restless leg sensations. And that these qualifiers have been correlated highly with the severity of restless legs, specifically in clinical series. This is a 56 patients in the French population, and a cohort series of the French RLS Association. And that correlation is as high in the treated patients and as well as in untreated patients. Moving forward with the relationship between restless leg sensation and pain, it seems that the RLS sensation may be more similar to neuropathic pain, because they use the descriptive used by patients with restless legs are more toward the neuropathic pain descriptors. And here again, looking at this clinical series from the French population of sufferers of restless legs, the words they used are itching, tingling, burning, prickling, electrical, really words that we use frequently when we want to describe neuropathic type of pain. And if you take those only three words, electrical, tingling, burning, they cover up 70% of that series of patients. So just to say that really they use mostly neuropathic pain kind of words to describe their RLS abnormal sensations. And also it is important to know that restless legs is associated with several painful conditions. There's painful neuropathy, specifically small nerve fiber damage neuropathies. Migraine headaches has been associated with restless legs, fibromyalgia, as well as other musculoskeletal pain syndromes. Moving forward to the neurophysiology of how that can be intricated between the RLS sensation and pain, it has been shown from quantitative sensory testing, where we evaluate the pinprick and pressure evaluation of patient with restless legs. Here, studies have shown that patient with restless legs, either primary, not related to any fiber damage or neuropathy or any other secondary cause, and secondary RLS, both exhibit what we call hyperalgesia to pinprick, which it means increased sensitivity to pain. That has been seen similarly in neuropathic pain syndromes. Also, the overall restless legs patient in this small study, for example, have been shown to have an increased heightened involvement of regions in the brain that subserve the emotional or medial pain system, like the amygdala, the anterior cingulated gyrus, the right thalamus, the orbitofrontal cortex, and that has been correlated with the severity of restless legs. All these data just mounting up that overall the restless legs syndrome may actually be a form of pain, even though that has not, the restless legs has not been classified as a pain form in pain textbook or in the pain community. Moving forward, also there is data from a treatment of restless legs that hints that restless legs is very similar to pain. And actually, pain drugs that we use on a daily basis for treating restless legs, and currently with the new guidelines, the class of medication called alpha-2 delta ligands like pregabalin, gabapentin, and acarbel have been now first-line therapy for treating restless legs because they are very effective. And also opioids at very low dose have been very effective in treating restless legs, and they are considered in refractory restless legs or as last resort for people who are very resistant to other treatment. So that is overall giving a summary of restless legs as a possibly overall pain disorder. Now, moving forward, there is actually a painful form of restless legs that have been also characterized, where a subtype of restless legs group do perceive actually their abnormal sensation as painful. And there has been data to characterize more and more that painful form of restless legs. Initially, our modern understanding of restless legs has been described by this guy, Carl Axel Ekbom, a Swedish neurologist, first characterizing restless legs, modern restless legs in 1945, but in his seminal thesis, PhD thesis that he published, he did characterize for the first time actually the painful form of restless legs that he called asthenia crurum dolorosa, versus the painless form of restless legs that he characterized as asthenia crurum paresthetica. And actually in his severe patient clinical series, almost 1/3 had that painful form of restless legs that he characterized as difficult to diagnose and to treat. And he specifically dedicated a full chapter for that painful form. Over the years, since then, nothing has been published until recently in the 21st century, where several clinical series have been published and, ask the question about if there is a painful perception of the restless leg sensation by the patient in those clinical series. Most clinical series from Europe show that up to half of patients with significant restless legs, the ones that come to the clinic to be diagnosed and treated, can have a painful form of restless legs. In other places in the world, like South Korea, it's a little bit less, 1/4. In South Africa, a little bit less. This probably may be related to how you pose the question of, is your restless legs, you perceive it as pain, but also could be related to ethnic and cultural difference backgrounds. Moving forward with the French RLS Association study from 2015, up to 55% of the subject would characterize their RLS as painful, and it's more in the treated subgroup versus the untreated subgroup. And in the rest general population study, where they they wanted to study the prevalence of restless legs in the general population of different European countries, including also the US, the painful RLS was present in the RLS sufferers, meaning patients who had RLS at least 2-3 times per week for at least moderate to severe. 59% perceived their restless legs as being painful, and 19% of them considered the painful RLS to be the most bothersome symptom. Also, the painful RLS has been shown in a small study to be topographically more extensive, meaning specifically involving the upper limbs and specifically involving the forearms. That's just to illustrate it, more the forearms here compared to the non-painful, and the same frequencies for the legs and the lower extremities. Also, this painful restless legs form has been shown to be more severe. Here, just illustrating with the International Restless Leg Study Severity Scale in the RLS French Association group of 738 subjects. Overall, the painful RLS are more score highly on that scale compared to the non-painful, and also even if they are treated or non-treated, they would score higher. Over these last years, several studies have characterized further that painful restless legs. The group by Karroum et al. In 2015 did characterize it as more sleepy. The patients are more sleepy when they are painful and tired. They are more severe. They have more severe symptoms, have higher need for dopaminergic treatments, and they have a sensory and affective descriptors that have a more severe connotation. While Cho et al. From Korea, Korean population, showed that the painful RLS may have lower ferritin levels, have a more severe restless leg symptoms, anxiety, depression. They scored higher on those and have a lower quality of life. And on the sleep studies, polysomnography, they had longer sleep onset latency, so it took them more time to fall asleep, and they have lower periodic lag movement. Remember that what I talked about initially, the involuntary periodic lag movements that can happen, not happen. They are seen in majority of patients with restless legs. More recently, a study from China showed that the painful form of restless legs was about 9% of the population of a clinical series of almost 360 patients. And based on, again, on the International Restless Leg Study Group severity scale, they are more severe. Okay. Also, another study from South Africa, again, showed that 1/3 of the population of this clinical series are painful. And they, based on the International Restless Leg Study severity scale, they score higher. And also on the McGill Pain Questionnaire, they score higher. So based on those studies showing that from a clinical standpoint, there may be a distinct form of painful restless legs, we did a study in Emory in Georgia University, where we tried to see if one of the primary genes that have been associated with restless legs is also associated highly with that painful form. What we got is that in a Caucasian population of 199 patients, where 1/5 of them had painful restless legs, one gene came out, and actually specifically one allele. So every genes in our DNA have 2 alleles that can be similar or different. One of these a gene called TOX3 gene, a variant of that gene, so a SNP, we call it, some variation of area in the DNA close to that gene, have been associated with the painful form, and specifically the minor allele of that gene. Here, just to illustrate, more you have an allele, more odds that you have that painful form. If you don't have that allele, it's less likely you have that painful form. These are the primary genes that have been associated with genome-wide association with restless legs initially, and that's just to illustrate that this TOX3 gene has been more highly associated with restless legs. Moving forward, more recently, from Australia, there's a twin study group that has been studied for many years, and based on 3,909 randomly selected twin families from Australia, where they were sent questionnaires, they also studied in kids, this in pediatric population, if there's any difference between those two phenotypes, those two forms of restless legs, painful restless legs and painless restless legs. Of course, they eliminated the growing pains before doing that study, because growing pains are very common in that population. And what they found out that the painful RLS seems to be more familiar and genetic compared to the painless, and seems to be more associated with primary pain disorders like migraine, like recurrent abdominal pain in kids, and while the painless RLS seems to be more associated with chronic pain syndromes and iron deficiency. More close to us, and I was involved in that study with the same group from Australia, led by David Champion, where now they also studied the same thing in adults, twin population, in that in 1,449 adults that responded to the questionnaire in that twin study. And what they showed up between the painful and painful restless legs is that, again, the painful RS seems to be associated with many pain syndromes, growing pains, recurrent abdominal pain, migraine, headaches, dysmenorrhea, chronic spinal pain, while the non-painful, again, has been shown in adults to be associated with iron deficiency, as well with other metabolic issues, obesity, hypertension, as well as vitamin D, while both forms or subtypes have been associated with anxiety and depression. So in conclusion, where do we go from here? We have characterized the painful RLS as a more severe and unbearable clinical variant of RLS. Is that in the same spectrum of the same disorder? In that case, is there any differential effects of medication on painful versus painless RLS? Is there the painful RLS, painless RLS, would it respond better to dopaminergic agent and iron therapy versus the painful RLS? Would it be more responsive to alpha-2 delta ligand like gabapentin, pregabalin, gabapentin, and acarbel, and opioids? Should we validate already used pain scales like the McGill pain questionnaire specifically for painful RLS? Because that's a dimension that is not well developed in the International Restless Leg Study Scale, which is widely used for evaluations of the severity of restless legs. The other option also that we need to investigate further is the painful RLS is a distinct phenotype than the non-painful RLS. Specifically, should we explore the small fiber neuropathy in painful RLS versus non-painful RLS based on quantitative sensory testing, so neurophysiology testing, and skin biopsy that we usually use to distinguish that type of small fiber neuropathy? Should we replicate the TOX3 gene results in larger and more diverse population with and without painful RLS, as well as compared to healthy controls? And should we extend the above analysis that I just discussed about the genes primary discovered for restless legs to multiple newly identified risk loci in RLS? There's more than 70 of them that has been now associated with restless legs as a whole. All these are good questions, I think, to be investigated in order to more characterize that subtype of restless legs or painful restless legs. More recently, we did present as an abstract with the group from Harvard that are following opioid treated patients with refractory restless legs. They have an opioid registry, over 500 patients they have been following over now 3-4 years. They published data over 1 year and 2 years to see if they increase their usage of opioids over time. And what we did specify with the study that group, but dividing them into the painful and non-painful subtypes. And what we find out is that the painful over 2 years, the painful subtype have a change in their increase in their morphine equivalent dose, meaning they increase the dose of morphine in general or change their morphine dose more than the non-painful. And the increase is basically more increase, but also more decrease in their dosage of opioids, total dose. And also the quality of the pattern of opiate change over 2 years more for the painful versus the non-painful or the painful group, where while the painless group, the pattern stays the same for most of the patient. For the painful group, they switch to other opioids or they remove opioids. So whether the higher need for change in opioid dose of medication in patients with painful RLS is related to the severity of RLS and or lack of efficacy remains to be determined. We probably, there is data over 3 years, 4 years, 5 years to follow up that population. We recently also wanted to characterize that difference between painful and non-painful based on a new therapy that have been FDA approved recently, the NIDRA, the perineal nerve stimulator, and that data will be presented hopefully in the next sleep meeting. But just to say that we are trying to further investigate that painful form of restless legs in order to be able at least to have a more individualized treatment options for painful. One of that would be to more characterize that phenotype, but also to characterize in the future other phenotype based on gender, age at onset, among other things. But it seems based on the data that the painful form is one phenotype to be considered more thoroughly in the future. That's just to illustrate what I just discussed about of the change in opioid in the painful compared to the painless groups. And on that, I finish with that conclusion that I just talked about. And with that, I thank you for your listening to that talk. And hopefully, we will have more research and studies in the future on that very interesting subtype of restless leg. Thank you.
Eccoci di ritorno. Io ringrazio ancora il professor Karroum per questo interessante seminario sul dolore. Ringrazio voi che ci avete ascoltato e l'Associazione Italiana della Sindrome delle Gambe senza riposo per aver organizzato questo seminario. E rimando ai prossimi seminari augurandovi una buona giornata.